Welcome back to the deep dive. Today we're really digging into something fundamental for Canadian nursing practice. How to navigate the high-stakes world of drug therapy safely.
It really is high stakes. I mean, think about it. Patients are often sicker, the population's aging, and the medications themselves are just incredibly complex. Plus, you have this mix of prescribed drugs, over-the-counters, natural products.
Yeah, it's a lot to manage, so that challenge, it really demands a solid, systematic approach, right?
Exactly. And that's what we're focusing on today, the framework that underpins it all. Safety, ethical practice, accountability. It comes down to the nursing process, those 5 phases, combined with the professional standards for giving meds.
The 10 rights, yeah.
Yeah.
We'll get to those. So our mission for you listening is to really break these down, not just list the steps, but get into the why,
Wow.
critical thinking behind it.
Absolutely. It's about understanding the practical steps, yes, but also how they fit together to keep patients safe.
Okay, so let's unpack this. The core engine, you could say, is the nursing process. It's described as this flexible 5-step cycle. Everything starts with gathering information, right?
That's it. Phase 1 is assessment. This is where the nurse, collects, reviews, and really analyzes all the relevant data about the patient, obviously, but also about the specific drug itself.
And we talk about subjective versus objective data.
We do. Subjective is what the patient or caregiver tells you their concerns. Symptoms like dizziness, their history as they report it.
Stuff you can't directly measure.
Right. And then objective data is, objective. Things you gather through your senses or measure vital signs, height, weight, lab results, what you find in a physical exam.
But the real skill here, isn't it, is comparing those two. Like, what if the subjective report doesn't quite match the objective signs?
That's exactly where critical thinking comes in. The patient says their pain is 10 out of 10, but objectively, their vital signs are stable, they seem comfortable. You have to use your judgment, evidence-informed practice to figure out what's really going on.
And part of that assessment, that data gathering, is the medication profile. It sounds simple, but it's got to be comprehensive.
Oh, absolutely comprehensive. And this is where things often get missed. It's not just prescribed drugs.
Right.
It's everything. OTCs, even things like vitamins or antacids people might not think count. Natural health products, any folk remedies they use. And crucially, you need to know about alcohol, tobacco, any illicit drug use. It all affects how drugs work.
You need the full picture.
Yeah.
And even before you think about giving a drug, there's the prescription itself. Got to check that order.
Always. Every single time. There are 6 things that must be there legally and safely.
Let's list them. Patient's name.
Date the order was written.
Drug name or names.
Dosage amount and the frequency.
How it's given the route.
And finally, the prescriber's signature. If anything's missing, illegible, ambiguous, you stop.
You absolutely cannot proceed. You have to clarify. That's non-negotiable.
Professional responsibility, plain and simple.
Okay, so you've gathered all this data. Now, step 2 is synthesizing it, making sense of it. That's nursing diagnoses.
Right. And this isn't a medical diagnosis like diabetes. This is about the patient's response to their health issues or potential issues, especially related to their medication.
And there's a specific way these are usually phrased, isn't there? Like a 3-part structure.
Often, yes. Part 1 is the human response, something like deficient knowledge or risk for falls.
Okay.
Part 2 explains why they're related to factors. So deficient knowledge related to lack of experience with medication regimen,
Okay.
maybe add, and grade 2 reading level, get specific.
And the third part.
That's the proof, the as evidenced by inability to perform a return demonstration of, say, using an inhaler.
Got it. And you have to prioritize these, right? Can't tackle everything at once.
Absolutely. Prioritization is key. You usually start with the most critical things, think ABCs, airway, breathing, circulation, and actual problems always rank higher than potential risks.
Makes sense. Okay, phase 3, planning. This is where you set the targets. We talk about goals and expected patient outcomes. What's the difference?
Good question. They're related but distinct. Goals are the broader aims. They should be objective, realistic, measurable, patient-centered, and have a time frame. Like, patient will understand their medication regimen before discharge.
Broad. Okay. And outcomes.
Expected patient outcomes are much more specific. They're the concrete, observable patient behaviors that show the goal is being met. They act as the yardstick.
So for that goal about understanding the regimen, an outcome might be?
Something like, patient will correctly state the name, dose, timing, and common side effects of warfarin by end of teaching session. See, specific, measurable patient action.
Right. It's about what the patient will do, not what the nurse will do.
Yeah.
That's a common slip-up, isn't it? writing outcomes about nursing actions.
It is. The outcome has to be patient-centered. It describes the patient's achievement.
Okay, phase 4 is implementation. This is the doing phase, right? Carrying out the plan.
Exactly. This includes independent nursing actions, things you do based on your judgment, like patient education. It includes collaborative activities, working with physio or dietitians, and, of course, implementing medical orders, like administering medications.
And this is where safety protocols really come into sharp focus. But before we jump into the rights of medication administration, you mentioned something important weaving through all of this.
Yes, two huge concepts. Critical thinking, that's the foundation for everything. Analyzing, applying standards, reflecting, and evidence-informed practice, EIP, using the best current research evidence to make those clinical decisions.
And these concepts are crucial because the nursing role itself is expanding, especially here in Canada. Nurses aren't just, passively following orders anymore.
Not at all. While most registered nurses don't order medications in the traditional sense, some RNs with what's called certified practice can actually administer certain meds without a direct physician order, but based on very specific, pre-approved agency protocols.
Like for a fever or constipation.
Exactly, like pyrexia protocols or bowel protocols. It requires extra training and certification. And then in some provinces, Ontario, BC, Alberta are examples. The scope has broadened even more. RNs might be allowed to dispense certain medications in specific situations.
Dispense. Like a pharmacist.
In a limited way, yes.
Oh.
Maybe for patients going on a day pass or for discharge meds in some settings. It's controlled, but it's a significant expansion of responsibility.
And then we have the roles that do involve prescribing.
Right. Nurse practitioners, NPs, these are RNs with master's or doctoral degrees. They have the legal authority to diagnose conditions, order diagnostic tests, and prescribe medications.
So they function much more like primary care providers in many cases.
You do. And then there's the physician assistant, PA role. It started in the Canadian Forces, now it's in civilian healthcare too. PAs practice under the supervision of a physician, and they can also write prescriptions.
So as a nurse administering medication, you need to be aware of who prescribed it, MD, NP, PA, and understand the scope and regulations around each. It adds layers of complexity.
It definitely does. Which brings us neatly back to the safety net. The system had to evolve beyond the basic 5 rights.
Yeah, the original 5 rights, they felt a bit too focused on just the individual nurse doing the check, didn't they?
They did. And errors often aren't just individual mistakes, they're system failures. So the framework expanded to the 10 rights of medication administration. These are really the baseline standard of care now, reflecting a more vigilant and system-aware approach.
Okay, let's walk through these. We need to really grasp the nuances. Starting with the first one, right drug.
Simple in theory, complex in practice. The core rule is checking the drug order against the medication label 3 times before administering.
3 checks.
Okay.
And using the generic name is best practice.
Absolutely. Generic names avoid confusion between sound-alike or look-alike trade names. You should always use current, reliable resources like the CPS, the Compendium of Pharmaceuticals and Specialties to confirm.
Even if the patient only knows the trade name.
Especially then, you need to confirm the generic name, maybe educate the patient too.
Okay, next. Right dose. Never assume the dose is correct.
Never, and orders can be incomplete. Remember that example, an order for acetaminophen 2 tablets PO.
Right, that's incomplete because
Acetaminophen tablets come in different strengths. Is it 325 milligrams, 500 milligrams? 2 tablets of which. The order needs the specific milligram strength.
Good point. And related to dose, those decimal points. Huge source of errors.
Massive. The rule is always use a leading 0 before a decimal point for doses less than 1. So write 0.25 milligrams, not 0.25 milligrams.
Prevents it being misread as 25 milligram if the decimal is missed.
Exactly. But crucially, never use a trailing 0. Don't write 2.0 milligrams. Just write 2 milligrams, because if that decimal point gets missed or isn't clear,
it could be read as 20 milligrams, 10 times the dose. Potentially catastrophic.
Precisely. Avoid trailing zeros at all costs.
Okay, next. Right time. This one has evolved a bit, hasn't it?
Yeah.
The old 30-minute rule isn't quite as rigid now.
It's more flexible, based on recommendations from groups like the ISMP Institute for Safe Medication Practices. They recognize that for many routine meds, giving them exactly on the hour isn't critical. There's usually a window, maybe an hour or 2 before or after the scheduled time, depending on the drug and facility policy.
But some timing is still critical.
Oh, absolutely. Stat orders, meaning immediately, still generally need to be given within 30 minutes. And things like antibiotics often need precise timing to maintain therapeutic blood levels. PRN orders, those given as needed, require assessment first. You don't just give pain medication because it's available. You assess the patient's pain level, check when the last dose was given, and then decide.
Makes sense. Then, right patient. This seems obvious, but errors happen.
They do. That's why Accreditation Canada mandates using at least 2 unique patient identifiers before giving any medication.
2 identifiers, like,
Usually the patient's full name and their date of birth, or their name and their hospital registration number. Comparing the medication administration record, MAR, against the patient's wristband is standard practice.
and what's not an acceptable identifier.
The patient's room number. Never use the room number. Patients get moved.
Good reminder. Okay, number 5, right route. Check the order, specifies how the drug should be given: PO, by mouth, IV, intravenous, IM, intramuscular, subcut, subcutaneous, etc., and that it's appropriate for the patient.
And that you're using the correct technique and equipment for that route.
Right. Now, the next one is sometimes called the 6th right, but is absolutely essential. Right documentation.
Crucial. And the key principle here is document after you give the medication, never before.
Why not before? Seems efficient.
Because what if something happens? What if the patient refuses the drug right at the last second, or they vomit it up immediately? If you've already documented it as given, the record is inaccurate and potentially unsafe.
Ah, okay. So administer first, then document immediately after.
Correct. And documentation includes not just routine administration, but also any variations if a dose was held, why it was held, if the patient refused, any assessments related to PRN meds, and very importantly, any medication errors.
Let's talk about errors for a second. If an error happens, you document the facts in the patient's chart, right? What was given, patient's response, actions taken.
Yes, the objective facts go in the patient's medical record. But the separate incident report or safety report, the form you fill out for the hospital's quality improvement and risk management, that incident report does not get mentioned or included in the patient's chart. It's a separate internal document for system analysis and learning. Keeping them separate is important for legal and professional reasons.
Got it. Okay, we've covered the first 6 rights. What about the remaining 4?
Right. Number 7 is right reason. You need to understand why the patient is getting this specific medication. Does the reason align with the patient's history and diagnosis?
Even if it seems obvious.
Especially if it doesn't seem obvious. Sometimes drugs are used for off-label reasons, purposes not officially listed but supported by evidence. The example often used is lactulose.
Which is classified as a laxative.
Right, but it might be ordered for a patient with severe liver disease, specifically hepatic encephalopathy. In that case, the reason isn't constipation, it's to help lower high ammonia levels in the blood. The nurse needs to know that therapeutic rationale. If you don't understand the reason, you need to ask before giving the drug.
Okay. Number 8, right response. This links closely to evaluation. You need to monitor the patient and assess if the drug is actually doing what it's supposed to do. Is the pain medication relieving pain? Is the blood pressure medication lowering blood pressure?
And are there any adverse effects, any unwanted responses? That's part of assessing the right response, too.
Makes sense. Number 9 is right to refuse. Patients have the right to refuse any medication.
Absolutely. Competent adults have autonomy. If a patient refuses, your job isn't just to document it. You need to try and understand why they're refusing. Are they worried about side effects? Do they not understand why they need it? You might need to provide more education or clarification.
But ultimately, if they still refuse,
You respect their decision, document the refusal and the reason, if known, and inform the prescriber. You don't force them.
okay. And the 10th right.
Right. Education. Patients need proper information about their medications, what it's for, how to take it, potential side effects to watch for, what to do if they miss a dose. This is a core nursing responsibility, especially for discharge planning.
So those 10 rights, they really create a comprehensive safety net.
They do. They force you to pause and think critically at multiple points in the process.
Which brings us back full circle to the last phase of the nursing process. Evaluation.
Exactly. This isn't just a final step, it's ongoing. You're constantly evaluating. Did the plan work? Were the goals and expected outcomes met?
How's the patient responding therapeutically?
Are there any adverse effects? Any signs of toxicity? You're monitoring, reassessing. It's a dynamic loop.
And if things aren't working, if the goals aren't met, or the patient has a bad reaction,
Then that evaluation feeds right back into assessment. You gather new data, maybe revise the nursing diagnosis, adjust the plan, implement the changes, and evaluate again. The cycle continues. It's never really done.
so pulling it all together.
Yeah.
What's the big picture here? The Canadian nurse today is working in a really complex environment.
Immense complexity, high accountability, but they're guided and hopefully protected by these two pillars we've discussed. The systematic approach of the five-step nursing process and those rigorous safety checks embedded in the 10 rights of medication administration.
And thinking about the future, technology is changing things rapidly too, isn't it? Electronic health records, mobile devices for communication and documentation.
Absolutely. And that adds another layer of responsibility. Safeguarding patient information using strong passwords, logging off systems, maintaining confidentiality in digital communications, that's become an integral part of safe practice. It's woven into everything, ensuring both privacy and safety. It's not just about the drug, it's about the whole system, including the information system.
That's a really important point, all interconnected. Well, this has been a really thorough deep dive into the foundations of safe medication practice.
Hopefully, it provides a clear map for navigating this crucial area.
I think it does. We hope this has been helpful for you listening, clarifying how these frameworks support safe, ethical, and effective nursing care. Thank you for joining us on the deep dive.